Hello, my name is Luke Belville. I'm at the Institute for Exercise and Environmental Medicine, which is part of the Texas Health Presbyterian Hospital Dallas and the University of Texas Southwestern Medical Center. Today I'm going to be presenting on exertional heat stroke, best practices for pre-hospital providers, alongside my colleague, Dr. John Jardine from the Corey Stringer Institute. What I'm going to be presenting today is the result of some work when I was at the Corey Stringer Institute, housed at the University of Connecticut, really focused on connecting the field to the ER. And so what I mean by that is what we looked for was an opportunity to take the best practices that we know from athletic training and sports medicine and connect them to the world of emergency medicine. Because working with a lot of athletic trainers, we saw that a stumbling block that a lot of athletic trainers had was that they would be able to follow the right procedures, or they would be able to establish the right policies and procedures, only to face interruptions in the care of an exertional heat stroke when it actually came to the EMS. Coming to the scene, and then later on the emergency room. So I, along with Dr. Jardine today, will talk about the consensus statement that we developed with the colleagues shown here to really identify the key features of successful care of an exertional heat stroke. And that's the key measure I would like to talk about today, is that this is essentially at the point that the exertional heat stroke has occurred. We're going to talk a little bit about a diagnosis and assessment, but this is really the key link between the emergency care provider as the athletic trainer and the emergency care provider as the EMS. And hopefully we provide you some tips and tricks to allow you to better collaborate and better establish policies and procedures with your EMS colleagues in your community. I'm going to start by talking a little bit about the epidemiology of exertional heat stroke, and we're going to highlight a few key points throughout this as our global considerations for the treatment of exertional heat stroke. Just to keep this a little bit timely and a little bit relevant in terms of the greatest scheme that's going on, Dr. William Adams recently highlighted, and several others have highlighted, that this summer in particular, and this coming school year, represent a unique time of vulnerability for our student athletes. With COVID, we have individuals who are going to be vulnerable in multifaceted ways, in terms that they've probably been less physically active than they've ever been, less heat acclimatized than they have ever been, and going into, and what we hope is minimized, but we still will happen, is coaches perceiving that they need to catch up for that time. And what we think this is going to create a perfect storm for athletes to be at their most vulnerable for things like exertional heat illness, among other conditions. So actually some researchers at the Corey Stringer Institute established a consensus statement endorsed by the organizations you can see there to establish some return to sports and exercise during COVID-19, and to help provide practitioners with some tools in that toolbox to be able to return athletes safely. But overall, what I want to touch on is that globally, we can understand exertional heat stroke is really, in the epidemiology of the literature, is captured in 4 situations I'm going to talk about. Military, formalized athletic settings, occupational settings, and then running and mass participation endurance events. If we first look at military EHI, what we see is a trend whereby the hospitalizations, the ambulatory visits, and the total recognizable events of exertional heat illness have continued to increase over the previous years. And what's interesting about this is, despite fighting wars over in the Middle East, where it is very hot and humid, overwhelmingly, the majority of these cases occur in the United States. In particular, these cases occur primarily during basic or right after basic training, when individuals lack heat acclimatization, when they lack fitness, and are going through grueling events. What you can see here is the first three bases indicated here account for about 30% of the total exertional heat illnesses encountered by the U.S. Armed Forces, and they are all significant training bases. So for those of you who are athletic trainers working in the military setting, it's important to understand where this risk happens, and what we see is that it's primarily during training events, not during actual live combat situations. If we look at it from an occupational standing, what we can see here is primarily wildland firefighters, crop workers, and construction laborers are the key three groups that are targeted by this. All three of these cases are from the National Institutes of Occupational Safety and Health. And there are actual findings in cases where employers were fined, in the case of some of these, hundreds of thousands of dollars as the result of lawsuits due to negligence on their part because of workers dying from exertional heat stroke. We can see also where these happen in two of these cases, one in California and one in North Carolina. And unsurprisingly, as with the military EHS and occupational EHS, we see globally increasing trends of not only the number of cases that are happening, but the rate at which these cases happen when that's indexed against the total population. In this case, this is from crop workers, but just illustrates that this is becoming an increasing problem. Next, we talk about the third out of our four total groups would be road races. Road races being mass participation endurance events. In this case, we're looking at the Falmouth Road Race, which is a road race held in Falmouth, Massachusetts in the middle of August, and has typically one of the highest recorded rates of exertional heat illness per 1,000 runners. And what we can see in terms of the predictability of this actual incidence of exertional heat stroke is that in terms of, we look at the y-axis here in terms of the rate of heat illness or heat exhaustion or exertional heat stroke per 1,000 runners in comparison to the x-axis, which is the wet bulb globe temperature, we can see that there's a predictable increase in the number of cases as the wet bulb globe temperature increases. So therefore, as humidity and as heat increases, we see an increase in the number of cases. If we look at this similar, this is a combination of three different races that has recently been published on the Boston Athletics Association 10K Beach to Beacon, which is a race up in Maine, and finished at the 50, another road race. We see the same trend of an increase in wet bulb globe temperature predictably increases the number of exertional heat stroke or exertional heat illness events that are seen. And to note about these particular in road races is we typically see it in between the 10K and the half marathon is where most exertional heat strokes also occur. So we can even narrow down that predictability nature even more. Now, if we look at formalized athletic settings, so your high school, your collegiate sports. In particular, if we look here at, this is high school sports, we can see where across these different sports, we see the incidence of exertional heat illnesses. So this is severe exertional heat illnesses would include heat exhaustion and heat stroke. In this case, there was no recorded heat stroke, but heat exhaustion. And unsurprisingly, we see that boys football in both competition and practice overwhelmingly dominate the rate of exertional heat illnesses. Other sports still do have them. You can see that sports like girls field hockey and lacrosse, baseball still have instances of these. And what's important to keep in mind is we see the news reports about an athlete dying from exertional heat stroke, or we see it on Facebook or Twitter of these athletes dying. We think it's a fairly isolated event. The fact of the matter is, if we break down these epidemiological numbers, if in a school with about 700 athletes, one severe EHI, so one heat exhaustion requiring major medical intervention from an athletic trainer, typically would happen a year. So for those of you working in the high school setting, you can kind of scale this in your mind in terms of how often you will see this. If we look at NCAA sports, unsurprisingly, we can see the same exact trends. Men's football accounts for the overwhelming majority of these cases, primarily occurring in practices, but also occurring in terms of athlete exposures fairly frequently in competitions, followed by men's wrestling, and then a smattering of other results there. And if we look at EHI in terms of football, what we can see is we can even narrow that down further. And as no surprise to any athletic trainer who's practiced for any period of time, preseason football in particular is the most vulnerable time for athletes. Whether it's youth, whether it's high school, whether it's college, you can see the staggering amount in terms of proportion of exertional heat illnesses that occur during preseason football compared to pretty much any other time of the year. We can narrow this down a little bit more by looking at the geographic spread of this. So this was some work done by Andrew Grunstein out of the University of Georgia, and looking at the geographical and the meteorological distribution of exertional heat strokes across the United States. And what we see is that in this case, in cases between 1980 and 2009, overwhelmingly, the southeastern United States, with a smattering of a few cases in California, Arizona, account for the majority of exertional heat stroke, primarily due to high heat and humidity. And this is further illustrated in this table from Grunstein, which shows, based off of the American College of Sports Medicine and WBGT guidelines in terms of risk and practice modifications, we can see where the majority of them occurred. And the majority occurred during high and extremely high risk categories. So your black flags, your categories where you're supposed to minimize heat exposure as much as possible, was where the majority of exertional heat strokes occurred. And what we can see is that just like we saw trends in terms of the military and the occupational heat stroke deaths occurring, we can see also the impacts of climate change on WBGT, which we think will also impact the rates of exertional heat stroke. So in this instance, what we'll see is that on the left map, we'll see is the distribution of essentially days where you would have to modify practice in most states. And this varies a little bit by region now as policies have adapted. And you can see the frequency there. Well, this is modeled out based off of indices of climate change, and it's actually back from 2003. It probably would be a little bit more aggressive now. You can see that parts of the United States begin to have 100+ days where they would have to modify practice to minimize the risk of exertional heat illness. So this becomes a very salient issue as these factors combine, and now we layer in this COVID pandemic to essentially create this perfect storm of we need to address this. And as athletic trainers, we are really well poised to address this. And that's what hopefully Dr. Jardine and I can illustrate to you today is this. So that brings me to my first consideration. Exertional heat illnesses primarily occur in a predictable fashion. And what I mean by this is that it's not a grand mystery. And there's no, random nature essentially to when exertional heat illnesses occur. We know the activities when they occur most commonly. We know the weather conditions when they occur most commonly. And we also know a whole host of risk factors that you can learn from other documents about what individuals are particularly in risk. And if we look at cases in the past 5-10 years, we can see the repeated warning signs that that were prodromal for these cases leading to this. A lot of it cases where the individual was not feeling well the night before. A sudden heat wave came on. We see it a lot in football because they were wearing equipment. So the point of this, and when it comes to coordinating with your EMS providers and your medical systems, is to understand when these are going to happen. And these are the times to talk to your EMS providers and say, hey, give them a heads up that, hey, we've got a couple high schools going on with football practices. We just wanted to touch base to let you know that this would happen. And we're going to touch on this a few times during the day, because the important thing to remember is that when an EMS provider shows up on scene, they don't often have all the information that you have. And this is where you can become a key ally to that emergency medical care provider to help them provide care by providing them the context and providing them the information, because they could equally be showing up at the same time to a motor vehicle accident, a drug overdose, as they're arriving to your football field for an exertional heat illness. Next, we're going to start talking about exertional heat stroke recognition and care. So we know essentially when these exertional heat strokes are happening, what do we do about them in order to coordinate care so that it's a seamless transition from that person being treated to being transported to the hospital to hopefully recovering fairly quickly. So there's a couple different documents that you should be aware of as an athletic trainer. The NHCA position statement is a very key one. The Inter-Association Task Force Preventing Sudden Death in Secondary School Athletics Programs is also a very good one. This is a high-level overview of essentially the steps that you should be making as athletic trainers and athletics programs to minimize the risk of sudden death. The same thing goes for collegiate conditioning sessions. Collegiate conditioning sessions are a particular time of risk for athletes, and is a key focus area for when we should be targeting our interventions to minimize the risk of sudden death. And then finally, this consensus statement, which once again is hopefully in a concise way, bridges the gap between the National Athletic Trainers Association position statement and the ACSM position statements into the emergency care world. It's published in Pre-Hospital Emergency Care for a reason. That is the National Journal for EMS Providers and EMS Medical Directors. As part of this, when we came together with this expert group at the Corey Stringer Institute, we came up with essentially these 4 steps that need to be completed for an exertional heat stroke to be successfully cared: rapid recognition, rapid assessment, rapid cooling, and rapid advanced care. And what I'll do is I'll go through the first 2 and lead into the third, and Dr. Jardine will be talking about the last 2 steps. So in terms of rapid recognition, what we mean by rapid recognition is recognizing the individual who has exertional heat stroke fairly early on. This is being able to be there as an athletic trainer and identify this individual out of the group of them and helpfully minimize the list of potential conditions of that collapsed athlete, of that athlete who's struggling, so that you can properly triage them to more advanced care. So I'm not going to go through this. Essentially, what's important to remember is that from an exertional heat stroke pathophysiology standpoint, this increase in body temperature affects nearly every organ system in the body. It causes a global inflammatory response. It increases metabolic rate. It causes primarily liver damage, kidney damage, affects the central nervous system, and this all occurs in a cyclical fashion, so that essentially once an exertional heat stroke pathophysiologically has started to happen, these individuals will continue to progress worse. If you simply having this individual stop exercise typically will not resolve their conditions. In fact, it will usually make things worse because they need to be cooled so importantly. So it's important to break this chain of this pathophysiology with early intervention. As I said, this affects nearly every major system. Musculoskeletal system leads to rhabdomyolysis. Renal can cause arrhythmias. Liver damage is a hallmark sign of exertional heat stroke. And severe cases of exertional heat stroke almost always, if they survive, require liver transplant. Disseminated intravascular coagulation, which essentially is just coagulation throughout the entire body in small vessels, is a major medical complication. These things that lead to this sequela of exertional heat stroke that ultimately lead to death is fairly severe. What I want to do in terms of recognizing this exertional heat stroke is illustrate through a couple of cases that Dr. Doug Costa and I worked on for a book chapter to show you what were some typical cases in terms of athlete behaviors that they present with exertional heat stroke. So in this one case, this was at a summer road race, 40 to 49-year-old female. She was found in the fetal position near the recovery and rehydration radio area, just covered in the in the fetal position, just saying that she wanted to drink some Gatorade. In this case, we were able to cool her, and she said that she felt hot after the race and just kind of collapsed over by the hydration area. This is a fairly typical presentation where it's the post-race collapse where there's no other kind of thing brought on about it, and it's a key way we can distinguish between heat illnesses and, for example, cardiac conditions. In terms of altercation at Torrey, so this is showing the other end of the spectrum where the last patient was fairly subdued. In this case, what we can see is a 44-9-year-old male at that same road race was acting all out of sorts. A police officer went up to him to see what was going on because he was making a big stir. He goes up and punches the police officer. As all of us know, generally that response from the police officer is that point to arrest them. They attempt to arrest him, and luckily a medical staff member noticed this, and knowing that that's not normal behavior from someone, said that they might be experiencing an exertional heat stroke, had them brought to the medical tent, and they were evaluated and had an exertional heat stroke and actually didn't remember anything at all. So if we look at these two cases, and we're going to talk about the diagnosis of exertional heat stroke, but it's important to recognize the overall signs and symptoms of exertional heat stroke. We see nausea, vomiting, diarrhea, loss of muscle function, mood disturbances, hyperventilation, seizures, tachycardia, hypotension, and alterations in consciousness. And these alterations in consciousness can range from anything to complete loss of consciousness and being in a comatose state to just mild mood disturbances. So this covers a wide gamut of the signs and symptoms of any condition. And so what's important to remember is that in isolation, giving this information to an EMS dispatcher is not very helpful, because when we are calling EMS, we have to remember the more global setting that we are encountered, and that EMS dispatcher could be dealing with someone who's suffering a heart attack. They could be dealing with someone who could be suffering a drug overdose. So when we give them nondescript symptoms and we just say we had an athlete collapse, we are providing those medical care providers any additional information to be able to do their jobs. What instead we're providing is this nondescript thing so that the EMS have to come in and do more investigative work when they come in. Whereas if we can provide them a fairly targeted information and skill set, and we've pre-briefed them that, hey, we have a heat wave coming through, we think there may be a potential for this, it narrows their focus and allows us to streamline that communication. And this is illustrated really in this last case that I'm going to talk about. So this is from an NCAA Division III baseball practice. This was the first day of non-traditional season practice. So they were practicing in the fall. This happened to be in Georgia. Ambient temperatures were in excess of 90 degrees Fahrenheit. This was a freshman baseball player. This coach decided that their first day of practice, they were going to have a 4-hour practice. During this time, he kind of stumbled, fell down, wasn't looking too good. There was no athletic trainer on the scene. He remained conscious and was able to respond to questions. They put some wet towels on him and they called 911. Once again, this was coaches communicating to 911, essentially just said that this athlete had collapsed. When EMS arrived, they removed the towels and moved the patient to the ambulance, as is standard practice. However, once inside that ambulance, that patient became combative, saying, "Why would you try to give me money?" and declaring, "She's trying to kill me," to about a female EMT. He then tried to escape the ambulance. All right. And so what ended up happening was because the EMTs were not able to subdue this patient and were able to treat him, they waited for police backup. And as a result, they had to delay any treatment they could give him by about 15 minutes. And he didn't end up making it to the hospital probably until about an hour after he collapsed. Luckily, he survived this, but he has suffered long-term sequelae as a result of this. And it's very easy for us as athletic trainers to go and say, oh, well, they didn't do cold water immersion. They didn't cool him in the ambulance. But when you have a suddenly erratic person who EMS are dealing with, and we don't provide them the context clues, and we don't provide them the tools that we can potentially provide them as athletic trainers or athletics programs, we miss the boat a little bit because, once again, is that EMT now, and they declared this, that they were thinking that this person might be on drugs. this person might be suffering some other kind of brain condition. And so we have to be able to do our duty as healthcare providers to communicate this information in terms of assessment. And that begins with the phone call to 911. We can go and do all our policies and procedures, but if the simple act of saying, we suspect it's an exertional heat stroke and we're going to do X, Y, and Z, and you have a plan in place with those emergency medical care providers, is going to streamline that process and any potential conflicts that we all worry about where, oh, what if the EMS come and take him out of the tub? Or what if the EMS come and I have to defend myself? We can streamline that communication, have these conversations up front and have them talking about evidence rather than individual patients. We can really move this process along much quicker when it actually happens. So with that in mind, there are a lot of differential diagnoses in an athletic setting, from exertional heat stroke, dehydration, infection, epilepsy, hypoglycemia, hyponatremia, drug intoxication. This is just in an athletic setting. And just to hammer this home is that the EMTs, when they arrive, could be thinking that this is could be a whole host of different things that we need to help them identify and narrow their focus in a constructive way and have that conversation in a constructive way. So it brings me to my global consideration number 2. Exertional heat stroke presentation is variable. As you saw, based off some of the cases, it ranges from combative behavior to somewhat subdued and comatose behavior, but situational information can help direct appropriate care. So now that we talked about rapid recognition, rapid assessment. So we have a suspected exertional heat stroke. We now need to essentially narrow in our diagnosis as athletic trainers so that we can start providing care, and then we can also communicate what the next steps of care need to be for those emergency medical care providers. The key with this is that exertional heat stroke assessment boils down to 2 issues. And that's 2 diagnostic criteria: neuropsychiatric dysfunction. This is a very broad term, and as you saw in those cases, ranges from slight mood changes, and it's actually possible that individuals have what we call a lucid interval, where this individual seems totally fine, totally coherent, and then they rapidly deteriorate. We've seen this happen where an individual this will happen in the course of 5 minutes. But really the key is that this neuropsychiatric dysfunction and the presence of number 2, this deep body temperature, this internal body temperature or core body temperature greater than 40.5 degrees C at the time of collapse. And there's a couple key things there. So that greater than 105, and it has to be at the time of collapse. So if we look at the differential diagnoses, just going through some of the conditions we had just talked about, we can see the importance of that body temperature. A lot of different conditions cause CNS dysfunction. For example, heat exhaustion also can present with CNS dysfunction, so can hyponatremia. Concussions absolutely present with CNS dysfunction. Loss of consciousness, also the great example. Exertional sickling can cause loss of consciousness, so can hyponatremia, and cardiac conditions. Diarrhea and vomiting are very nondescript. So this was really where that body temperature and getting that accurate body temperature measurement becomes so critical to the measurement and the diagnosis of exertional heat stroke. It's really what distinguishes exertional heat stroke from all the other conditions, and it's your immediate trigger to begin treating this as an exertional heat stroke. So when it comes to body temperature assessment, we have to think about what method we're going to use. And it essentially boils down to 2 things. What's going to be a reasonably valid measurement of body temperature, and what's logistically feasible. And what do I mean by this? If we look at valid measurements, there's a lot of valid measurements that are used, for example, in ERs and ICUs that are highly reflect the internal environment. And when we say deep body temperature, what we mean by that is we want some central measurement of the body's organs. The idea being that the hotter those central organs are, your heart, your brain, your lungs, that's where we start to see protein breakdown and lead to that EHS pathophysiology we had talked about earlier. So very commonly used is esophageal, urinary bladder, pulmonary artery inserted via central venous catheter, and gastrointestinal measured via ingestible pill. The problem with these measures is they don't meet the criteria on the right. That is logistically feasible. And those are things that athletic trainers are going to be able to do in the field. It is very hard to do an esophageal temperature on someone who is unconscious. Urinary bladder and pulmonary artery and gastrointestinal measurements are highly invasive maneuvers that really need to be done in sterile environments. Meanwhile, we do have these logistically feasible measurements that you can do in the field in terms of oral in terms of ear canal, AURAL, temporal in terms of forehand scanning, things like that, and axillary. The problem with these measurements is they aren't valid. What we've found is that across many different studies is that the validity of these measurements, they might be okay at rest for detecting something like a fever. However, once that individual starts exercising, the skin environment that these are all measuring is very different than what's actually going on deep inside the body. Which brings us to why we do rectal temperatures as athletic trainers for the assessment of exertional heat stroke. As of right now, it is the only measurement that we have that meets the criteria for both being valid enough for us to actually diagnose an exertional heat stroke and be confident in that diagnosis, and also logistically feasible in a field environment. What's important about the second part of that earlier statement about it being a temperature greater than 40.5 degrees Celsius, which is 105 degrees Fahrenheit, is the second part of that statement was at the time of collapse. And so this is a paper by Dr. Adams, Dr. Hasakawa, and Dr. Kasa, looking at what it's mathematically modeling out essentially if we were to look at when an individual collapsed versus when we took their temperature, and how the treatment intervened there. So what we can see in scenario A is that if an individual is noticed right as they collapse, their temperature there is a greater opportunity for their temperature decrease in that window, that 30-minute window that we really want to treat exertional heat strokes in. We essentially have a greater number of cooling modalities available to us to treat them. In situation B, where we see an individual was slightly delayed in us picking up on that temperature, all of a sudden at the bottom here, we only have one modality, aggressive cold water immersion, to be able to treat that person appropriately. And then finally, if we don't capture that person right away, essentially no matter what we do, we can't cool that person down in that key time window. So that's why it's important to remember that an individual presenting with a body temperature of above 40.5 C, we have to take that as based off of when they collapsed. Because in addition to these scenarios where the temperature continues to increase, if that person has been collapsed or has been hyperthermic for a prolonged period of time, they might not present with a temperature that is so high. If there's a delay in, for you example, as an athletic trainer getting there because they were on a remote field, or the coach didn't call it in, it becomes much more challenging to use that 40.5 degrees Fahrenheit criteria. So it's not an absolute rule out criteria, but it is a rule in criteria. Which brings to the last step. And what this is rapid cooling. And Dr. Jardine's going to touch on this a lot more in terms of rapid cooling and rapid advanced care. But I just want to touch on two key concepts here. Is that the criteria for external cooling modalities, whatever they are, and they have to provide sufficient cooling capacity, and that's essentially how cold they are in terms of temperature and the specific heat, how effective they are to transmit that heat to a body, and the body surface area covered. Essentially, the more of the skin surface area covered you cover with an external cooling modality, the more cooling you're going to be able to provide. So what we came up with as part of this document, this consensus statement, is this algorithm that is free to use. Please feel free to use it for simply assessing the of a potentially exertional heat stroke person. And this is written in a similar format to that many EMS departments use. So please feel free to share with your EMS colleagues. It's a great point of communication here. And it basically breaks down the 4 steps in a similar way. If an individual is not responsive, you need to provide emergency care. If they have disturbed CNS dysfunction and a rectal temperature greater than 40.5 degrees C, initiate cooling and transport them to advanced care. The key part to remember with this is thinking from both your standpoint and thinking from an EMS provider standpoint. What resources does this plan require, and what communication can we have up front to be able to provide those resources? Which brings me to my final consideration. On-site assessment and recognition reduces delays in treatment that jeopardize patient outcomes. So putting this first half all together, remember that exertional heat stroke occurs in a predictable fashion. We can be better about understanding the situations where we think exertional heat stroke is going to happen and provide those resources to, one, hopefully prevent it, but two, if they do happen, be ready to act and have those points of collaboration ready to go. Exertional heat stroke presentation is variable, but the information you provide as an athletic trainer and as a pre-hospital care provider is crucial to help direct care. And that ultimately helps reduce delays in treatment that is so important for the optimization of outcomes in exertional heat stroke. With that, I'd like to thank you. My email is listed here, and Dr. Jardine will be covering the rest of the presentation.
Welcome to Establishing Pre-Hospital Treatment Paradigms for Exertional Heat Stroke, Part 2. My name is John Jardine, and I'm going to present the in-hospital side of the paradigms. Conflict of interest, I am the medical director of the New Balance Falmouth Road Race, and I will be referring to the road race throughout my presentation. However, I receive no financial compensation in that position, so I have no other disclosures. So like I said, my name is John Jardine. I had my beginnings in EMS. I was a New York State paramedic for about 10 years prior to going to medical school. I'm now a board certified emergency medicine physician, and I have been so for about 20 or so years. I've also, as I mentioned, I'm the medical director of the New Balance Falmouth Road Race for the past 20 years or so as well, where I've treated more than 370 cases of exertional heat stroke. I'm also the chief medical officer for the Corey Stringer Institute at UConn. So in EMS, and back in my days in EMS, and certainly still today, there's this conundrum of making decisions in the field, and it's scoop and run versus stay and play. So is it, somebody that has to quickly get to the hospital, or is there time to do some interventions in the field? And certainly there are time-sensitive diagnoses in which we're asking EMS to make very specific choices in the field. We're told that time is muscle when we talk about acute myocardial infarction or acute MI, that's best treated with timely intervention by cardiac catheterization and stents. And then now more recently we're told that time is brain when it comes to acute stroke, where interventions are most successful if they're administered within a specific time frame. So again, these make it sometimes difficult for EMS to make decisions in the field based on these time constraints. So I would argue that exertional heat stroke is another of these diagnoses that benefits from timely intervention. This was a study done in the 1970s using rats, and it was shown that as time passes, the likelihood of surviving decreases, and you have about 30 minutes to institute life-saving treatment to assure survival. So what I'm going to talk about is two different scenarios for exertional heat stroke, one in which you're prepared for the occurrence of exertional heat stroke, and one in which it becomes an emergent problem. So if you're organizing an event, if you're the medical organizer, first of all, you need a core of volunteers, both medical and non-medical. You need to reach out to the local police for things like traffic control. Of course, you need to have the local EMS service on board for the transporting of patients. And you should touch base with the local hospital for workflow overflow that can be anticipated from your event. It's a multiple disciplinary attempt to provide medical care. This is my team at the Falmouth Road Race. You can see that sometimes it takes a village. This is crew of close to 200 people that are put together to assure the safety of runners at the Falmouth Road Race. And what you have to do is you have to provide education for these volunteers, right? You have to educate them regarding what protocols will be in place and what procedures will be used on the day of the race for the care of patients. Some protocols may actually supersede the local EMS protocols, such as transporting a patient to a medical tent as opposed to going directly to the hospital. And we talk about the 6 H's that can cause someone to collapse in one of these events. First of all, being heat or heat illness, heart, of course, acute coronary syndrome or sudden death by cardiac arrest, hyponatremia or low sodium, hypoglycemia or low sugar, a hemoglobin crisis such as a sickling crisis from sickle cell trait, and of course head injuries, which fortunately we don't see a lot in race medicine. So the next thing you have to do is sort of position yourself in a place where you are able to provide help. You can see in the foreground there, that large white tent is our medical tent just past the finish line at the Falmouth Road Race. In dealing with the heat part of our race, or the heat illness part, in particular exertional heat stroke, we looked at this article that was published back in 2007 that defined the gold standard for exertional heat stroke treatment. And it said that the key to maximize the chances of surviving an exertional heat stroke is rapidly decreasing the elevated core body temperature. So how do we do that? Well, they looked at various cooling methods and the cooling rates associated with these methods and showed that ice water immersion was clearly superior to any of the other methods that were tested. So this is an ice water tub, an example of an ice water immersion tub that we use at Falmouth. It's a heavy plastic stock tub that's typically used to feed livestock or care for livestock. And again, I don't have any financial disclosures, but certainly they can be purchased at farm supply stores or tractor supply stores. And we actually prefer this type of tub because of its durability. Back in the beginnings of the Falmouth Road Race, we used kiddie pools, the sort of the plastic kiddie pools that you can buy in the stores, and found that they were certainly not as durable as these tubs. So I've also volunteered at some other notable races around the country. This here, of course, is the Boston Marathon. And you can see that at the Boston Marathon, they have a heat deck set up with immersion tubs if needed at the finish line of the race. Now, the Boston Marathon is in April, and the weather in New England is certainly variable in April. I was there in 2012 when it reached 95 degrees, but I was also there in 2018 when it was near freezing. So you never know. This is another race in Boston. This is the Run to Remember. This run finishes indoors in the convention center, but again, we use the cold water immersion tubs there. This is a race that's run in May. This is the Marine Corps Marathon. It's run in October. And again, these are immersion tubs. They have a little bit of a different protocol at the Marine Corps Marathon where they sort of hover the patient over the tub, but nonetheless, it's a water immersion type method. These are some tubs at events that I have not yet attended. Upper left is the New York City Marathon. Lower left is Japan, in preparing for the Olympics this year, or what was supposed to be this year. And then you see the Netherlands on the right. We had the honor last year of having a physician from the Netherlands join us at Falmouth to learn about cold water immersion and how we did it at Falmouth. She took that technology back to the Netherlands, and they used it at a very important race that they run in Amsterdam. They were able to treat exertional heat stroke there with immersion therapy. So this is our tent in Falmouth, and the reason it's so big is that we have several ice water immersion tubs set up, as you can see. Because we have about 13,000 runners that are depending on our team for their safety in the heat. Our data over the years shows that we see about two patients with exertional heat stroke per 1,000 finishers. So that's about 20 patients a year. This is an example of a runner who suffered exertional heat stroke and ended up in the immersion tub into finish line medical tent. Dr. Belleville, who lectured prior to this one, stressed the importance of covering the most body surface area. So we use towels and circulate the cold water as it tends to heat up when it's next to these runners who have temperatures sometimes in excess of 109 degrees. So again, we looked at some of this data. This is back in 2014. We published this data set out of Falmouth. And at the time, 2014, it involved 274 cases of exertional heat stroke. Since that time, we've added about another 100. The important thing to recognize here is that all patients who were treated with cold water immersion at the Falmouth road race have survived. So this is our numbers through the years. Again, we average about 20 a year with some variations, as you can see, some very busy years and some not so busy years. Back in 2003, we were not using WBGT data, but when we look at it retrospectively, that was actually a black day that day. And we've looked at when our surge, when our surge comes through the medical tent. This is data from 3 years, and it shows the times when runners enter the medical tents. So it helps prepare for the surge capacity and the influx of patients during those times. Now, we do supply our local hospital ED with cold water immersion tubs in case someone sort of bypasses our medical system or somehow otherwise gets to the emergency department without being seen at the medical tent. And they are kept in the the decon room of the hospital, where there is a drain in the floor to prevent the buildup of water if they need them. So that's all well and good, and you say that's great, but what if I don't have a big tent, I don't have a big area for immersion tubs, or I don't have immersion tubs? So what do I do then? So that's when we ask you to think about tacos or think outside the box. And again, this is the taco method, or the tarp-assisted cooling method, and it's very effective in cooling. It involves a water-impervious tarp, ice, and water. Those simple ingredients. And in the picture, you can see that the patient is supine in the tarp, and the slurry of ice water is kind of sloshed back and forth by moving the tarp back and forth. And this, when you measure the cooling rate, this is almost as good as the immersion tub. So this is a very effective method of cooling. So now let's move indoors. Can we do this in the emergency department? And I work in a small community emergency room, and this is, a typical bed in a typical emergency department. Can we do this in the emergency department? Well, first we have to start with our temperature measurement, and how do we assess temperatures? In the fast pace of the ED, the nurses typically use temporal thermometers for rapid temperature assessments. Dr. Bell will tell you how important it is to get an accurate assessment of core temperature by using rectal temperatures. And if you look at the data from this study, you can see that temporal thermometers are sort of way off core temperature. They can be off by as many as 4 to 5 degrees, which certainly can lead to misdiagnosis of exertional heat stroke or other heat illness. So a rectal temperature is necessary for assessment of core temperature. So what do you do if you see one of these patients who's hyperthermic? Well, you go back to your EMS days and you say, well, I grab some ice packs, right? I'll put the ice packs in the net around the neck and the axilla and the groin, cover the major arteries with ice packs, and this should provide some cooling to the patient. Now, this review was published in the Journal of Athletic Training in 2009, and it investigated several cooling methods and measured the cooling rates for each of these methods. And much like the gold standard paper that we talked about from 2007, a cooling rate of 0.15 degrees Celsius per minute or greater is considered ideal for cooling a patient with exertional heat stroke. So where do our ice packs work out? Well, not so well. It's really an unacceptable cooling method. It would take way too long to cool someone by this method. Again, we have what we consider a time-sensitive condition, and we actually have to cool these people within 30 minutes. So this is an unacceptable way to do that. So let's take a look around the ER. What else do we have that we can use to cool somebody? Well, we have this cooling blanket, and it's essentially a plastic sheet with channels that run through it. And then the unit on the right pumps cold water through these channels. You place the blanket under the patient, and the circulation of the cold water cools the patient. So, yeah, it sounds like a good idea. How about this method? Well, this one barely makes a blip on our chart. This is very unacceptable as a cooling modality. Certainly doesn't do much more than just watching somebody in an air-conditioned room. So really not effective at all in cooling someone in the ER. What about chilled IV fluids? Well, we can keep some IV fluids in the refrigerator. When somebody comes in with heat illness or heat stroke, we can use these cool fluids, and we'll run the cool fluids through them, and that'll cool. How about that? Well, again, not so good. This is, again, not meeting acceptable standards for cooling. It takes way too long. There was a military study that showed that if you started an IV in somebody's hand or wrist, by the time the cool fluid got up to the level of the shoulder, it was already warmed to body temperature or sometimes above. So cooled IV fluids is not going to be effective for cooling patients. What about rotating cold towels? Just literally dunking towels into ice water and rotating them out as they warm up. Well, this is actually pretty good. This is an acceptable cooling rate. It may not be ideal, but it is certainly a good start. And this method is actually encouraged for EMS or for athletic trainers to start, as it really requires minimal equipment and is very easy to do. But again, I ask you to think of tacos and think outside the box and think of some other methods. This is a malignant hyperthermia emergency cart. The JACO, Joint Commission for Hospitals, recommends or mandates that any place in the hospital where you're using succinylcholine, which is a paralytic that can cause malignant hyperthermia, you have to have this sort of rescue cart available. So certainly in the emergency department, we're using succinylcholine, so we have this rescue cart that's available. And on our cart, we actually keep a postmortem kit or an impervious shroud. And really what it contains is a fluid impervious vinyl zippered shroud that you see on the right. So if you open the zipper, you add some ice and water. This is what I refer to as the burrito method, not the taco method, but similar to the taco method and certainly less messy in the emergency department. It contains the ice and water in a zipped up impervious bag. And we did show that, again, the taco method or in this case, the burrito method have rates that are almost similar to cold water immersion. So this is a very effective method of cooling. And this may be an effective way of doing it in the ER. As a matter of fact, this study was published last year. This is a case report of a group in California who actually used the burrito method for treatment of an elderly woman with classical heat stroke, not exertional, but classical heat stroke. She was found in her apartment and was hypothermic, and they had good results using this burrito method. It was our hopes this year that at Falmouth in August, we were going to actually study the burrito method and actually calculate cooling rates, but unfortunately the race was canceled this year, so we'll wait till next year. So if this is acceptable and this works, then maybe this is our answer for the ER. This is our answer to how we can cool people in the ER. But this is my ice machine. I can get you a cup of ice at a time, but we're talking about 10 gallons or so of ice needed for either the taco method, the burrito method, or immersion tub. So where am I getting this ice? Well, so we have an emergency plan in place that somebody can run to the cafeteria if the cafeteria is open, if the cafeteria has ice available. So again, we're kind of limited as to what we can do in the ER. I've talked to a lot of my colleagues about this. They know my passion about exertional heat stroke, and we actually had a patient come in with exertional heat stroke. A colleague of mine was working. He got out the shroud. He put the patient in the shroud. He sent somebody to the cafeteria for ice. And the whole treatment was delayed because the cafeteria couldn't figure out how they were going to charge the patient for the ice. So again, this is not the ideal situation. So when you revisit that gold standard study back in 2007, this was published in 2012, it was determined that to effectively treat exertional heat stroke, not only did you have to cool the patient, but you should actually cool them first before you think about transport. And this gave us our mantra of cool first and transport second. And this is sort of a case that illustrates that. This is a tale of two heat strokes. This was done by some colleagues at KSI, and it involves two male runners who were treated at the Marine Corps Marathon. One was treated at the finish line, and one was taken from the course. So you see on the left, the black circles here, this line here. This is the runner who finished the race, collapsed at the finish line, and was taken immediately to the medical tent. It was recognized that he had exertional heat stroke. He was put in on the heat deck. He was cooled with cold water immersion and cold water dousing. And you can see that his cooling rate was about 30 minutes. Again, that's our target. And he did exceptionally well and recovered well. The second runner collapsed at mile 24. He was taken from the course by EMS, and he was brought to a local ED. By the time he arrived in the ED, you can see that his temperature, when his rectal temperature was taken, it was almost an hour after he collapsed. So an hour after collapse. And then whatever cooling modality took place took about 80 minutes to cool him to a somewhat normal temperature. This patient suffered renal failure, liver failure, and was actually put on the liver transplant list. Fortunately, he did recover without a transplant and eventually did well. But you can see the difference in these two cases of heat stroke, cooling right away versus delayed cooling that occurred in the ER. And this is probably my favorite case of that sort of defines the cool first, transport second mantra. This is Gavin Class. Gavin played football for Towson University. It was a particularly hot day for practice, and Gavin collapsed. He was seen immediately by the athletic trainer. They immediately identified that he had exertional heat stroke, and he was immediately put into a cold water immersion tub, and 911 was called. Firehouse directly across the street. Ambulance arrives within 5 minutes, and what do? They take him out of the tub. They put him in the ambulance and bring him to the hospital. When he arrived at the hospital, his temperature was 109 degrees, and again, he was cooled at the ED eventually. But again, like the other patient at the Marine Corps Marathon, he suffered renal failure, liver failure, and went on to have 21 surgeries, including a liver transplant. Gavin is doing well today. He's a strength and conditioning coach because he was not allowed to return to football despite a legal case that went all the way to the Supreme Court. And Gavin goes around now and talks about his case and talks about how important it is to cool first and transport second. So EMS is protocol driven. We know that the protocols, if you work with EMS or you're familiar with EMS, protocols are sort of like cookbook directions with certain options that guide you through the treatment of various diseases and conditions. So I kind of ask you to, take a step back and think about cardiac arrest for a minute. And certainly you would agree that this is the severe, if not the most severe condition that certainly requires prompt recognition and treatment. So a few years ago in the state of Rhode Island where I practice, the EMS protocols were changed for cardiac arrest to say that the providers had to stay on scene for 30 minutes before actually transporting a patient with cardiac arrest to the hospital. So I heard about this, I saw this, I said, what is this? This is the most ridiculous thing I've ever heard. What kind of evidence is there that would suggest that you stay on scene for 30 minutes before bringing somebody to the hospital? And the evidence was this large study that was done in Japan. There were thousands of patients were enrolled in this study, and they showed that they had better neurologic outcomes if the providers stayed on scene from anywhere to 30 to 42 minutes. So why does that happen? Well, what does someone in cardiac arrest need? Well, they need compressions and they need electricity, and that's it. They don't need me, they don't need the ER, they just need someone doing good quality compressions and defibrillation if it's appropriate. And if the EMS people stayed on scene, these patients actually did better than being rushed off to the hospital. And it works. This was a report out of North Carolina that showed that patients were 3 times more likely to be saved by EMS if they stayed on scene for 30 minutes. And this was in a short 6-month period. They showed such an increase already. So now in Rhode Island, we have a protocol that says that EMS, when taking care of a patient with cardiac arrest, must stay on scene for a minimum of 30 minutes prior to transport. This is like a CPR first, transport second protocol, if you will. So we look at exertional heat stroke. Can we do this with heat stroke? Well, we can, and we did. This is a protocol out of Connecticut. We wrote this protocol for EMS in Connecticut, and it includes EMS taking rectal temperatures, staying on scene with someone with exertional heat stroke, providing adequate cooling, and cooling actually before transport. The other thing that it involves is if they come upon a scene where someone's being cooled, a situation like Gavin's, by an athletic trainer or other staff, they're to stay on scene until the patient reaches a safer temperature for transport. So this is a cool first, transport second protocol, and one of the first of its kind. So let's go back to Falmouth for a moment and just look back at our data. And we see that we certainly cool first and transport rarely. Almost 90% of our patients are cooled and discharged from the medical tent. And we've seen patients with temperatures in excess of 109, 110, even up to 112. So for me, the conundrum is really solved. Exertional heat stroke is a stay and play diagnosis that is best handled on scene by trained professionals. And the stay and play should involve active cooling first with considerations for transport second. Again, this is the cool first, transport second mantra. So this is our consensus statement that was published in Pre-Hospital Emergency Care last year. And we can use this statement as means of a summary. So first, rapid recognition. Again, recognizing the signs and symptoms of exertional heat stroke, certainly by a temperature greater than 40.5 C and an altered mental status as the definition. Rapid assessment with the use of rectal thermometry as the best assessment of core temperature, and Dr. Belville emphasized this point in his lecture. Cold water immersion for rapid cooling, or a method of cooling that is at least 0.15 degrees centigrade per minute. And remember to think outside the box with the taco method or the burrito method. And finally, rapid advanced care after cooling first. So remember, cool first, transport second. I thank you for allowing me to be a part of the athletic training world. And I do honestly feel that athletic trainers are healthcare and an integral part of our care team. Thank you very much.